just take a moment and introduce our first speaker today, who will then introduce the people who have joined him. And that is Nathan Cisneros, who is the HIV Criminalization Project Director at the Williams Institute at UCLA, which specializes in legal issues affecting LGBTQ populations. At the Williams Institute, Nathan is applying his training on quantitative social science to the impact of HIV criminalization laws on people with HIV. His other research interests include comparative public policy and the regulation of labor and employment. Nathan received his Master's of Science in Political Science from MIT and a BA in Japanese economics and political science from UC Berkeley. So I assume he did not sleep during his undergraduate career. And he is joined today by Kamaria and Jada, but I will pass it on to Nathan. Thank you.
Thank you for that lovely introduction. I did not sleep much as an undergrad, I confess. My name is Nathan. As you heard, I use he, him pronouns. I'm proud and privileged today to share this space with two wonderful colleagues and organizations, Jada Hicks from the Center for HIV Law and Policy and Kamaria Laffrey from the SERO project. What I'd like to do is start with Jada, an introduction from Jada, and an introduction to HIV criminalization, HIV Criminalization 101. Then I'll share some Williams Institute research findings, some of the who and how of HIV criminalization, and then we'll go to Kamaria to hear how people most affected by HIV criminalization are leading the charge to change these laws and policies across the United States. So with that, why don't I hand it over to Jada?
Thank you, Nathan, and thank you everyone for having me today and for allowing me to join this panel. I am just going to quickly touch on what I'm going to cover in my portion of the presentation. So I am going to introduce and explain essential terms associated with HIV criminalization, document the scopes and features of criminal laws. I'll touch on, I know Nathan is going to do a deeper dive into explaining the harms caused by criminalization, but especially for people who are Black, Brown, and LGBTQ+. So CHLP, a little bit about our organization. We're a multiracial organization that uses a Black feminist queer lens to analyze the issue of discrimination, criminalization, and oppression of people affected by HIV and other stigmatized health conditions. So HIV criminalization represents a facet of the broader oppression of people living with and deeply affected by HIV, especially Black people, LGBTQ+ folks, working class folks, people who use drugs, and people who engage in sex work. We envision a world free from state violence where people are not dehumanized and punished for their real or perceived health status and our identities, and where health conditions are not met with criminalization, surveillance, and other punitive responses. Next slide, please. All through 2025, we went through a process where we took a step back and asked ourselves the big questions, like what does it mean to build a future where people living with HIV and other stigmatized health conditions can live free from surveillance, punishment, and criminalization? So our new strategic plan begins to answer that question, and it really is a guide for how we're going to be engaging in our work. And I encourage folks to check it out if you really want to look at applying an abolitionist framework that is rooted in liberation. If you scan the QR code, it will actually take you to our strategic plan. Next slide, please. So I am the Senior Positive Justice Project Attorney, PJP. PJP is a central component of CHLP's work, and we work with state and local coalitions of people living with HIV, advocates, researchers, nonprofit leaders, government officials, and other stakeholders. Next slide, please. Okay, so I want to start with grounding us with our shared definition of HIV what we mean by HIV specific, when we're talking about criminalization statutes. So a law is HIV specific when it solely names HIV or uses an expansive definition of communicable disease that includes HIV, because it imposes criminal penalties or heightened criminal penalties on the behavior of an individual by explicitly singling them out based on their positive status. So the terms used to single out people living with HIV are going to be really diverse. And the language is going to vary from state to state and jurisdiction to jurisdiction. And it can include anything like communicable disease, contagious disease, infectious disease, sexually transmitted disease. A broad range of language is going to be used there, but all doing the same thing. So regardless of the exact language that's used, the effect is the same. Someone's health status is named, and it's used as a means to criminalize them. Next slide, please. So what do we mean when we say HIV criminalization? I wanted to start with outlining that HIV criminalization refers to laws, policies, and practices imposing that heightened criminal penalty on people living with HIV for conduct that is not criminalized or criminalized less severely for people not living with HIV. These increased penalties could manifest as distinct criminal offenses, such as exposure and transmission offenses, enhancements that increase the length of incarceration or fines, forced testing or treatment, or other severe penalties such as registration on the sex offense registry and compliance with those extensive restrictions. HIV criminalization could also occur through general criminal codes, so it doesn't have to be an HIV-specific statute. Here we're talking about things like aggravated assault, for instance. They don't specifically mention HIV or another communicable disease. And case law has been interpreted that these general criminal laws as being applicable to behaviors of people living with HIV. So example for aggravated assault, it would be the court classifying someone's HIV status as a deadly weapon. HIV criminalization is a product of inaccurate, stigmatized views based in queer phobia, white supremacy, and misogyny. These laws emerged from and perpetuate these prejudiced, ignorant ideas. And we know that from enforcement data that Williams Institute and Nathan are going to go over, that these laws especially affect people with intersecting marginalized identities, so folks that sit at the intersections, such as transgender and cisgender women, Black women engaging in sex work, LGBTQ plus people who use drugs. Next slide, please. I do want to get a little bit more into some of the nitty gritty. Sometimes folks get confused about this specific language, so I think it is helpful to define them. So among laws that are HIV specific, there are generally two types of laws, offenses and enhancements. So an offense is a law that imposes criminal punishment for engagement in certain behaviors. So this is going to be anything that is criminalized for people living with HIV, but not for folks that aren't living with HIV, such as having consensual sex or donating blood. Whereas an enhancement imposes a heightened punishment on top of an existing punishment. For people living with HIV, these are increased penalties for engaging in criminalized behavior, such as sex work or sharing drug use equipment. So typically, for example, sex work, that is a misdemeanor offense in most states. However, if you're a person living with HIV, it's going to be an automatic enhancement to a felony. Next slide, please. Offenses or enhancements can then be broken down into several different categories. So exposure, transmission, and non-disclosure offenses are often used interchangeably. However, typically these are separate and distinct offenses, and you have to look at the exact statutory language to interpret which activity is being criminalized. Under an exposure law, criminal penalties on people living with HIV for engaging in specific behaviors that purportedly create the possibility of HIV transmission, so such as having sex or sharing syringes, or more broadly, exposing another to HIV through any means or contact. This does not mean that there's an actual risk of transmission, but instead, the focus of the law is on the perceived risk of transmission. Transmission laws impose increased criminal penalties for the transmission of HIV from one person to another. So for that, we have to have SERO conversion. And a non-disclosure law. So while many states impose criminal penalties for exposure or transmission, some states additionally impose criminal penalties on people living with HIV for non-disclosure of HIV status to their sexual, drug use, or other partners. That is these states criminalize distinct behavior. So for example, in Indiana, they have a duty to inform law where people do not fulfill this duty to inform are punished through Indiana's failure to comply law. Next slide, please. I just wanted to briefly touch on some of the history of HIV criminalization. Excuse me, I'm so tongue-tied today. Legislation criminalizing the transmission or alleged exposure of HIV started in the 1980s in response to specific events and was largely fueled by homophobia and panic that the developing AIDS epidemic, perceived at that time as an exclusively gay male disease, would spread to heterosexual majority populations and communities. By the late 1980s, the federal government got involved, promoting HIV-specific criminal laws in response to rising rates reported among gay men. And President Reagan's 1987 Presidential Commission on the HIV epidemic recommended that states adopt HIV-specific criminal laws because they believed the existing penalties under assault laws were too lenient to deter intentional exposure. So several years later, the Ryan White Comprehensive AIDS Resource Emergency Act, or the CARE Act, was enacted, and it actually conditioned additional funding to states based on the fact that they had criminal laws that would address intentional HIV exposure and transmission. And so that's really where we see the proliferation of these laws. Next slide, please. I want to talk about some of the common features. So most HIV criminal laws, transmission is not required. Any activity viewed as sex and allegations of non-disclosure are enough. Risk of transmission is largely irrelevant. So it doesn't matter if you took risk reduction measures. It's not a defense to prosecution. Condom use, low viral load due to treatment, it doesn't matter. Whether you engaged in negligible or zero risk activities such as oral sex or spitting, they're still criminalized. It does not matter. In fact, just 2 years ago, someone in Ohio was imprisoned for a year for having oral sex without allegedly disclosing their status, even though we know that that is a negligible risk of transmission. So you're not going to transmit HIV that way. Intent to harm is rarely considered or required, so a person does not have to have the specific intent to expose or transmit HIV. And proof of disclosure is often the only defense, so one person's word against another's, which is exceedingly difficult to prove in a court of law. And these laws often impose severe and disproportionate punishment, so felony level punishment and sex offense registration occurring in 5 states. Next slide. I was just going to go over our maps. You can find them online. There is a QR code. It talks about the 32 states with an HIV-specific exposure or transmission offense, and breaking down our HIV specificity scale as well. I won't spend too much time on it, but just giving you an overview and a snapshot. Next slide, please, is just going to be the QR code. If you want to scan it now, feel free. If not, we can share the slides and you can visit our website afterwards as well. Next slide, Nathan, please. Thank you. And to be clear, there's no evidence that these laws improve public health. That is, there's no evidence that they deter behaviors more likely to result in transmission, promote disclosure, or reduce the number of new diagnoses. But there's broad and growing evidence that these laws actually harm our communities. They exacerbate stigma against HIV and people living with HIV. And stigma remains a huge problem, threatening the health and safety and well-being of people with HIV. They worsen barriers to HIV prevention, testing, and treatment services. They perpetuate a one-sided message about sexual health and prevention responsibility. It should not be the sole responsibility of the person living with HIV to engage in these conversations, but a shared responsibility between adults. These laws also disproportionately harm marginalized populations, including people of color, LGBTQ+ communities, sex workers, people who use drugs, and undocumented immigrants. And lastly, the laws undermine care and support for people living with disabilities, including people living with HIV, by reinforcing ableist systems that criminalize health conditions. Next slide. I just wanted to point out that we have been making some movement, recognizing these harmful consequences. Leading public health organizations and medical societies have denounced HIV criminalizations. And many of these groups also joined CHLP in developing a consensus statement opposing HIV criminalization. Next slide, please. I just want to point out that recent trends within its attacks on Black, Brown, and LGBTQ and immigrant communities, as well as women and femme folks, the federal administration has moved to defund, stigmatize, and criminalize health research and care. That makes it less likely that people will be able to access treatment and prevention services, and more likely that they'll be criminalized under state criminal laws targeting people with stigmatized health conditions. We have made some wins and some strides in the past couple of years. So North Dakota and Maryland became the 4th and 5th states, respectively, to repeal their HIV-specific offenses. But we continue to fight and we continue to bring our intersectional lens because there are states such as Louisiana where there are efforts to expand criminalization, and it remains a threat across the United States. House Bill 76 in Louisiana is one of those examples. It would have criminalized anyone living with an STI. So we worked with the Louisiana Coalition on Criminalization and Health to defeat the bill, turning it into a study resolution that will look for meaningful solutions to the STI epidemics, such as expanded access to prevention medication. So I think we are still wary and on the lookout for any sort of legislation that may actually expand criminalization, especially under the Trump administration, and knowing that they are taking more carceral approaches. My last slide, Nathan, if you'll progress the slides, is just a link to our source book. So if you want to learn more about how folks living with HIV can be subject to prosecution in your state, please check out the source book. It outlines punitive laws and policies and cases affecting people living with HIV in all 50 states and U.S. territories. And thank you so much. I will pass the microphone back over.
Thank you, Jada, for that wonderful introduction. And I'm going to now try to bring up my PowerPoint presentation and hope that I'm able to share. But hopefully everyone can see my slides. Why don't we go with the material as it's presented here? And as Jada says, we're happy to make the slides available to you afterward. My name, as you heard, is Nathan Cisneros. I use he, him pronouns. I'm the HIV Criminalization Director at the Williams Institute. The mission of the Williams Institute is really to provide fact-based, independent, rigorous, policy-relevant analysis to key stakeholders. That could be anyone from advocates to legislators. And we've been looking at HIV criminalization now for 10 years. I should say HIV criminalization as a phenomenon in the United States is actually 40 years old this year. In 1986 is the year in which the first HIV-specific criminal law was passed. So here's a roadmap of where I'd like to go. I'd like to step back. Jada gave us a brief history of HIV criminalization in the United States. I'd like to dive a little bit deeper, and then I'd like to share what we know about HIV criminalization in the United States from Williams Institute research. So let's start with some of that history. As Jada said, most of these HIV criminal laws were enacted at the height of the AIDS crisis in the 1980s. I have written down that many of the laws were passed before we understood how HIV is and is not transmitted. That's not quite accurate. We had good science on HIV transmission even in the mid-1980s, although that knowledge wasn't widely diffused, and certainly policymakers maybe didn't have access to that information, or at least not readily at hand. It was certainly before we had effective medications to both treat and prevent HIV. But when you look at the legislative record, you find that many of the laws were motivated by fear. The fear was often racialized. There was a lot of homophobia. In the early days of the AIDS epidemic, there was the association with the so-called four H's: homos, Haitians, heroin users, and hemophiliacs. Haitians in here is interesting. It's quite a coded term. It's being racially coded and then also coded for people who are not from the United States. And as Jada mentioned, the original Ryan White CARE Act tied some federal funding to the enactment of these criminal penalties. I won't belabor the point, but the media have not done a good job at covering HIV in general and HIV criminalization in particular. These are headlines mainly from the 1990s. If I pulled headlines from the last few years, they wouldn't be unfortunate. Well, they would be a little bit better, but I think that they would still be missing a lot. You still see a lot of medical misinformation. You still see a lot of assumptions and fear and stigma associated not just with HIV, but HIV transmission cases. This is a map that actually, or a plot that actually shows the year of enactment for HIV criminal laws across the United States. And I drew a red line there. That's when the Ryan White CARE Act came into force. And you can see many states actually had started criminalizing before Ryan White. And then you see a number of states afterward. And you can see actually Florida is one of the first states to criminalize HIV all the way back in 1986. But as recently as 2011, there was a new HIV criminal law in Nebraska. Let me give you an example of what two criminal laws actually look like. These are both from Indiana, both of them essentially criminalizing the same thing, that is fluid exposure, and really only fluid exposure in the context of exposures that cannot transmit HIV. So these two laws are essentially only criminalizing behaviors that we know are not HIV transmission routes. For example, spitting at somebody, throwing urine or feces at somebody, right? So it lands on somebody's skin or clothing. It's not an HIV transmission route. And yet we have two laws. One of them, the second, called malicious mischief, and passed as recently as 2002. We actually know how that law came about. This article was discovered by one of our colleagues in Indiana. The story, as reported in the news article, was that a high school student dumped warm water on another student, claiming it was urine. The child told their parent. The parent took them to the doctor. The doctor recommended HIV and hepatitis testing for the next 12 months. Again, this was water, but even if it was urine, this would not be medically appropriate here. A legislator found out about this, decided to introduce the law. That's what the malicious mischief law that's the origin of the malicious mischief law. And you can tell by the name how it's related to this story. Again, it only criminalized behaviors that cannot transmit HIV and singled out HIV and hepatitis for harsher treatments. Let me go into what we know about HIV criminalization in the United States. So who's being affected by these laws? And I want to give you a few covers. So we have 40 years of HIV criminalization in the United States, and now a decade, 10 years of HIV criminalization related research at the Williams Institute. And it's in small print, but that second name on our very first report on HIV criminalization here in California was Ayako. Ayako was critical in starting this line of research at the Williams Institute. And we've been fortunate enough to continue that research ever since. We now have 25 reports across 16 states, including here in California. And I should say, this report and a couple of others from that initial research push were instrumental in reforming HIV criminal laws in California. Unfortunately, people living with HIV still can be criminalized in California, although the circumstances are dramatically restricted. Let me give you a high-level summary of what we know about HIV criminalization across the United States, and then I'll show you the same information in a few figures. So
Nathan,
first,
can I
yeah,
just break in for 1 second? I'm
go
sorry.
ahead.
Just wanted to do a time check and say we have about 10 minutes left for both you and Jada to ensure we have some time for questions. So please keep that in mind.
All right, I'll be very brief. And maybe I'll just stay on this slide, and I'm happy to share figures later on. But I just want to emphasize most arrests and prosecutions are pursuant to laws that don't require transmission, the intent to transmit, or even a substantial transmission risk. We've counted just across these reports, thousands of people have been criminalized because of their HIV status. We know that criminalization is continuing to this day. Every state in which we request data, we find people being criminalized because of their HIV status. And we know that Black people, women, and sex workers are often disproportionately affected, sometimes dramatically so. And I'll share a link to a recent report on Black Americans and HIV criminalization in the chat. And additionally, we've seen that enforcement tends to be geographically concentrated. So this tells us that it's more about policing or prosecutorial practice than about public health. And finally, as Jada mentioned, there can be lifelong consequences, felony convictions, sex offender registration, which can really substantially affect your life course afterward and create its own cycle of criminalization. Why don't I stop there? I'll be happy to answer any specific questions in the Q&A portion, but I'll turn it over to my colleague Kamaria now and her set of slides.
So while Nathan's pulling that up, you can already just skip the title slide. So I'm Kamaria, use she, her pronouns, and I'm with the SERO project. And we're a network organization that centers the leadership of people living with HIV, including our staff, our entire staff of 6. We're a small little family. Does this work to end HIV criminalization, mass incarceration, racism, social injustice by supporting the inclusive people living with HIV networks and state coalitions to improve all the things. I won't read the whole thing because I'm going to talk more about what this looks like in a moment. Next slide. And just a little bit about me. I am a woman living with HIV for over 20 years. I think it'll be 23 this fall. I like to tell people I was born with chronic optimism and Black girl magic. And I also am grounded in this work through my lived experience and the belief in the power of the people. Next slide. So I want to start us off by, as I talk about lived experience and connecting it to what Jada and Nathan have shared, you when you're doing this work, the one thing that these 2 colleagues of mine, these great friends of mine, always model is MIPA, which is the meaningful involvement of people living with HIV. And that is the process of keeping us central to the creation and determination of policies, funding, services, research, and initiatives that affect us. So in all the work that Nathan and Jada have talked about, people living with HIV have been at the table to help ask the questions or share the information or amplify the strategies that come out from this movement work. Utilizing MIPA requires centering us as integral to the decision-making process in the HIV field. So that goes across anything, not just having us show up to receive services or offer feedback afterwards. Next slide. Some examples of leadership by people living with HIV is what I'm going to be sharing with you all. So from federal agency engagement to creating and moving state level policy, we are more than data points that you can create programs around. We are key to solutions needed to end HIV criminalization and other strategies that are implemented for us to get to an end of HIV. Our voices are needed from the onset, not as an afterthought. Next slide. One example of this is the U.S. People Living with HIV Caucus wrote the first ever policy agenda written by people living with HIV in a response to the National HIV/AIDS strategy when it existed in a friendlier time. So that's one example of how our voices were amplified and how we were able to get into rooms to talk about issues from research to quality of life to immigration to housing, anything that impacts our lives. Next slide. Another example, and one of my favorites, is how people living with HIV move legislation. Pictured here is Tim Jackson from Illinois. And the thing that I love sharing is that in Illinois, they repealed their HIV law during COVID. Like they were meeting with legislators, they were mobilizing and talking to people and having meetings, even while it was really hard to navigate how to get in front of legislators and how to continue your strategy or pivot your strategy from a coalition standpoint. The thing that's really significant about folks like Tim and other states as well is the majority of them all attended the HIV Is Not a Crime Training Academy, which is the only conference space that's hosted by people living with HIV, for people living with HIV. We rotated on conference campuses every year, every other year, correct myself before Tammy, my co-director, comes and gets me, every other year. So our next iteration of HINAC will be next summer. And we're currently in the RFP process to find locations. But they've all either hosted or attended the conference, met other people in their state to mobilize and build like a 30, 60, 90 plan, built a coalition, and then within X amount of years, were able to make some sort of significant change in their state. So the root source of MIPA does live at HIV Is Not a Crime Training Academy. Next slide. And then another example that I'm kind of proud of is another form of MIPA is implementing things that give folks other talking points and other methods and pathways of how to navigate these conversations. So I think it was 2021 when Biden declared HIV criminalization as a concern and an issue from the White House administration. I then decided the idea that's been living in my head for a long time since I came into this work was that it was time for us to have an awareness day, because one of the problems being based in Florida, a problem I was coming into was contacting public health folks and getting them to support um, um, different strategy points around talking to legislators. And a lot of folks didn't want to risk their job and had to separate their job from the issue. So this awareness day gave them an opportunity to have talking points without saying, vote on this bill or don't vote on this bill. So the awareness day is on February 28th. That day was chosen to highlight the two populations of folks who are most impacted by the laws. So it sits between National Black HIV/AIDS Awareness Day, which was February 7th, and Women and Girls HIV Awareness Day, which is March 10th, also highlighting Black folks and women as targets of these harmful laws. Next slide. And so ways that folks can identify if they're utilizing MIPA in their organization and actions is by looking at, and sorry, that's a little cut off there, but looking at your leadership and representation in your organization or your programs. What positions do people living with HIV and marginalized communities hold where you're working? Are you utilizing intersectionality? Have you considered how stigma and racism and sexism and all the isms and forms of oppression are operating in your organizational practices, especially by people who are caught in the crosshairs of being vulnerable to HIV? And then lastly, it's not lastly, this is not an complete list, but also looking at your leadership and representation overall, and how are we, people living with HIV, providing input into your organizational program, your research studies, the development of your grant. Not just are we included in the narrative of the grant, but did we help you write the grant itself, or other service deliveries. Next slide. Ways you can help in identifying that, and while you're navigating this, is if you have opportunities from your expertise space to build strategies for any of the following bullet points here, just make sure you're including people living with HIV, not as a token, but asking them, are they interested? Do they even want to learn how to do the thing that's listed here if they've never had that experience, such as giving testimony at hearings, writing letters to the editor? I'm hosting a op-ed letter writing session next week to address the Florida ADAP crisis that's happening there. And other ways to connect, other ways you can help is connecting with state advocates and the people living with HIV, working on decrim efforts in already established coalitions, or in a space where you can start one to ensure that people living with HIV are always at the forefront. And there's ways to do this without them having to be visible. Like they can be an advocate without having to visibly disclose or say that they're living with HIV. And there's ways to do this without them having to be visible. Like they can be an advocate without having to visibly disclose or say that they're living with HIV. Next slide, I think is my last. Yes. I think I made it. I think I made it in.
Thank you so much, Kamaria. Everybody, just a round of applause for our speakers, Jada, Kamaria, Nathan. We had a few questions pop up in chat. I just want to also just give a shout out to this resource that you all are creating, which is a fantastic, sort of how to center storytelling and collecting those stories. I will say that our work with legislatures indicate that personal narratives mean so much. And I really think that your work in making sure that MIPA is honored in changing these laws is really incredible. So I want to put that out there. I have a few questions that have popped up in chat, and I think just really quickly as we share resources in the chat, as well as a quick evaluation poll for us and our speakers. Do any of you all know about folks who may have been charged that didn't know about their HIV status before they were charged? I know that knowledge of your HIV status was one element of the crime in our California statute when we still had it. But I'm just curious if any of you have heard of affected folks who were charged even though they did not know their status.
I can speak to this and say that most state laws do actually require knowledge of your status before you are charged. That is one of the elements that they typically start off by saying, like, the person knows their HIV status and they engage in a particular conduct.
Thank you. Super helpful. So we haven't yet heard of any situation where that's happened. The second question is about talking about how HIV criminalization is operationalized through a variety of laws, not just the criminal code, but also public health laws. You know, we know that old school quarantine laws have been used to criminalize people with HIV. And so just curious about sort of how, right, how this work happens and whether when you all are doing your advocacy, are you tackling HIV criminalization across all fronts?
Right? Like, there, we have conversations all the time. Should we move this to the public health code? If there are more than one statutes, we're flagging them for coalitions. Unfortunately, political pragmatism is real and you can't always tackle them all at once. So there are states, for instance, where they've done work on their criminal legal code, but they haven't gone back for the public health code. And there is still a statute there that subjects people to criminalization that coalitions are looking to go back and try and repeal or reform. So we do look at it across the board and try to identify any and everywhere that people living with HIV or other stigmatized health conditions can be subject to criminalization, and make sure that we're either repealing or reforming those laws.
There is one last question. I think it's very much related, which is, I had a good colleague from law school mention the other day that a lot of folks think that that laws are like, it's like a phone book where we just update pieces of it and it stays consistent across the board. And what we know is that that's not the truth of it, that there are a lot of inconsistencies, whether it's between federal law or state laws, different state laws across the country. And so the question actually came in whether or not CHLP or the Williams Institute has experience with sort of bringing more alignment, right? Updating laws at the state level that might conflict with current federal laws.
I'd love to hear from CHLP, and especially in trying to tighten definitions. Often a reform will include language like substantial transmission risk, but then that's not defined in the law. And so then you need to go back to do a further reform.
Yeah, and in particular, I see the question in here about like the HOPE Act too, and I'm like, oh, maybe that's something that we should put in the Repeal Act. Like, states are preempted, and they should actually. Oh, go ahead.
I'm the first person living with HIV to donate an organ to another person with HIV in the United States, and I find it a bit disheartening that folks don't highlight Georgia's experience, because Georgia is a red state, and a lot of the advocacy around HIV criminalization focuses on non-disclosure. And in red states, let's be honest, Republicans don't care that people with HIV have a right to a consensual sex life. So you can't go with that argument to try and reform laws. And, I became part of Georgia's effort in 2015. In 2019, the first living donor organ transplants under the HOPE Act that allow people with HIV to donate became permissible. I didn't have faith in our legislature to change our HIV-related criminal laws, but to me, federally, the HOPE Act said, hey, we can do something that is actually criminalized in Georgia. And I thought it's probably easier for me to donate a kidney than it is for me to change Georgia state law. And it turned out to be correct. But because I did that, I went back to Georgia and said, hey, we have this conflict. Like, how is it that our state law prohibits organ donation by people with HIV, but federally is now permissible? And so that is, kidneys were the convincing argument for Republican lawmakers to decide that their HIV-related criminal, the reckless conduct statute needed to be updated. And I hope that by me getting on this Zoom, because I'm not affiliated with any organization, and I wasn't for the 7 years that I've been trying to promote organ donation by people with HIV because it is legally allowable, that people can use that in states where they haven't been successful in using non-disclosure as a means to update their laws, that let's go with the lowest hanging fruit of organ donation.
Thank you so much for sharing that story. And I want to say that your experience really squares with ours, even in a super, super blue state like California, where the only thing legislators had an appetite for early on was aligning with HOPE Act. So that was the low-hanging fruit. And you're right. That was the way in which we started the conversation on what decrim campaigns should look like across the board. And I think there's still so much work to be done, and I really do feel like the story is still being written. But we're so thankful for our speakers for coming today and getting us started on this conversation. I think that for those of you who are interested in the additional resources that are coming through the chat, we will be following up our presentation with a copy of the slides and with some of these resources. And hopefully we can, again, be part of continuing this conversation on HIV criminalization